Welcome back to the last session, and this session is will be a live session discussion. It's an panel discussion with actually 5 speakers. Yes, we have Dr. Amna Kashgari and Professor Tempany, Dr. Khalid Khashoggi, okay, and Professor Marcello Di Carli, okay, and physically, Dr. Lamia Jamjoom. I will just introduce them again, as in Dr. Amna Kashgari is a board member of the Radiological Society of Saudi Arabia and Consultant General Pediatric and Pediatric Neuroradiology, Assistant Professor of Radiology, King Saud bin Abdulaziz University for Health Sciences, Riyadh, KSA, and Professor Claire Tempany. She's a Professor of Radiology in Harvard Medical School and Vice Chair of Radiology Research, Medical Director, Advanced Multimodality Image Guide Operating Amigo Suite, Brigham Women and Women Hospital, Boston, Massachusetts, USA, and Dr. Khalid Khashoggi, Vice President of the Radiological Society of Saudi Arabia in Riyadh, KSA, and Dr. Lamia Jamjoom, the President of Radiological Society of Saudi Arabia in Riyadh, KSA, and Professor Marcello Di Carli, Director of Cardiovascular Imaging Division, Chief of Nuclear Medicine and Molecular Imaging, Brigham and Women Hospital, Boston, Massachusetts, USA. And we can open discussion. If there's any discussion on the ground, physically existing, or discussion from outside, online.
Hello, I'm Dr. Ahmed Naguib from Cairo, Egypt. I don't have really any questions, but I definitely enjoyed the session. Actually, I believe that Dr. Khalid's session was great. I really loved it. Of course, Dr. Lamia's, and actually I benefited a lot from Dr. Amna's presentation. I wasn't here for Professor Tempany, but I really thank you for this incredible session from the Saudi Society of Radiology. Thank you.
Thank you, Dr. Ahmed. Okay, I just have a question to Professor Claire Tempany. Just clarifying the role of multiple biopsies guided by ultrasound in the case of high PSA with no focal lesions detected in the MRI or ultrasound. Is this still a role for this biopsies, multiple biopsies, which may reach 16 biopsies, for example, and sometimes?
Yes, absolutely. If there's no target on the MRI and there's clinical system of prostate cancer, such as a rising PSA or a strong family history, then of course, and if the patient has had no prior biopsy, a transrectal ultrasound guided biopsy is advised.
Right. Is there some number of biopsies of these random studies, random biopsies?
It's a very good question. And there's no magic number, but depends on the size of the gland. So typically it's 10 to 15 or so.
I was just wondering, because I heard this number, which I believe it's a huge number. But anyway, still there is a rule. Thank you very much.
Yeah, because you don't know where to go. So you are sampling the whole gland. You're trying to do right, left, base, mid, everywhere.
Right. Thank you very much. For Dr. Khalid, you are doing great. Actually, I benefit very much about your presentation for the guided treatment or injection, intra-articular injection. I'm just wondering, in routine MRI for the joint, do you do as a routine MR arthrography, or it's just in case of injection?
Well, thank you, Dr. Ahmad, and thank you, Dr. Talat, for your kind comments. So in regards into if we're injection a joint for MR arthrogram, basically we do them for the indicated cases such as a labral tear. But what I was mentioning in the talk is that we also add a ropivacaine into the injection, which is a local anesthetic, which actually would have a diagnostic value in the injection itself, because the patient goes back to his physician with a pain diary, and if the pain decreases after the injection, then this means that the pain is coming from that joint, and that would give a good diagnostic information for the referring physician. And if the surgery is anticipated, then this will make the physician more comfortable to go ahead with his decision. So, and if I understood your question correctly, regards to do we do MR arthrogram routinely on all of the patients? We, in our practice in Saudi, do not do that, but there are practices worldwide that I have been in before that do MR arthrograms for all shoulders in patients who are less than 40 years old and who are actually active in their lifestyle, because differentiating labral injuries from regular rotator cuff tear is quite difficult clinically, and that would make the patient's journey as one-stop shop instead of having a non-contrast study and then the patient comes again for an MR arthrographic study. So I hope I have answered your question.
Yes, thank you. Because I have, and some of the orthopedic centers or sports injury centers, is that they insist all the MRI should be done after injection of gadolinium, particularly for the shoulder, of course. So this is, it depends on the situation, and especially for labral tear, as you mentioned. Thank you very much. Forgot to mention
Correct.
that Dr. Talat sent apologies for not attending, moderating this session. I'm Dr. Hatem, the chairman, local chair of the conference. Thank you very much, Dr. Khalid. Now, my last question is Dr. Lamia. I was discussing with her about the role of MRI in using the T2 star only. And I believe that she mentioned that in most of the cases, you just use T2 star and sometimes use other sequences.
No? Yes. Thank you very much for your question. So actually, it's a specific exam dedicated for measuring iron overload in patients who are receiving frequent blood transfusion. In our country, mostly patients with thalassemia major. Now, sometimes we may add other exams which are not specific for iron overload itself, but for the assessment of the cardiac function in general, to see whether this iron overload, if it was present, has affected the cardiac function or not. So we may add the functional assessment, measuring the ejection fractions and looking at the myocardial motion in these patients.
Okay.
Other patients have different types of exams, so they don't actually get the T2 star MRI if they don't have anything that would predispose them to having iron overload.
Right. Okay, thank you very much. And I also leave if any of the speakers need to do any comment or any comment on the other talk or their presentation. No comment, okay. I think by this we'll close, yes? We'll close. Okay, thank you very much. I think we'll close the session. Thank you for very high-level discussion and presentation for everybody. Hope to see you physically next year or after 6 months. Thank you very much. Session is closed. Thank you. Thank you. Now, I think we have to close the last day and the whole conference. And just wanted to mention that this conference, although it was remotely and done as the first time physically and virtually, I think among the other international conferences, but still this year we have 2,000 attendants, mainly virtual or remotely. And this is exceptional because last year, when this conference was physically only attending physically, it was 1,200 attendants. So we have 2,000 attendants this year, and we'll have next one, inshallah, on January 2022, between 24 and 27th of January. See you next conference. Thank you very much. Alhamdulillah. شكرا جزيلا دكتور.
Thank you very much.
Thank you. شكرا.